I welcome all of you. Dr. Jaydip, who is a consultant diabetologist, and he has done a lot of work in diet nutrition. Dr. Tushar Rege, who is a general surgeon. I think detailed introduction will be done by the moderator today, who is Dr. Amit Nagate. So we are celebrating the World Diabetic Week, which is normally celebrated as a World Diabetic Day on 14th November. And we where the sign is a blue circle, so that is why this blue tie. And the theme for this year is well-being, physical, mental well-being, societal well-being. So that is why this topic of nutrition, which Jaydip talks so nicely, Dr. Jaydip, on nutrition, we have selected. And then we have Dr. Rajiv going to talk on judicious use of antibiotics. I'll be talking about preventive aspect of diabetic food, what preventive surgeries are coming up. And then we'll have a panel discussion of people who have joined. And I think initially this is a program of D-Food International, which is based in Brussels, Belgium, and there are 156 countries. So if you see the link, there are about 7 continents celebrate the diabetic week every day. There is one day allotted to each region. So our region, India is the largest thing, and then we have certain other countries like Bangladesh, Sri Lanka, and we have RSSDI going on parallelly, so maybe the audience will be less, but this is a annual function that everything we do it. So I do it in Khan Bahadur Kurla Baba Hospital. You may be doing in your places the celebration of Diabetic Day. So that is how we are today. So we all know that 14th November, why 14th November? Because Frederick Banting, who discovered insulin, his birthday is on that day. So the UNICEF and WHO, they decided to have this day on 14th November. And that is how it was recognized all over the world, and people are celebrating, making people aware socially as well as the doctors aware about diabetes and related complications. And as we are in the D-Food International program, we will be talking about diabetic food primarily and related topics. So I think, Madam, we can have the address of the President of D-Food International, and then we can start with the program.
It is an honor and privilege to address you today as President of D-Food International. I speak not only to the diverse and vibrant individual present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. D-Food International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle income countries. As diabetes rates surge, so does the incidence of diabetes related complications, including food related complications, which is our focus of action here at D-Food International. Our mission of D-Food International is resolved and clear, ending avoidable lowering amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare professionals are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at D Food International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign we find each one of you as a faithful ally in this great endeavor. The success of D Food International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of D Food International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, D Food International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
So that was Professor Dr. Abbas from Tanzania. He's a consultant physician, endocrinologist, and diabetologist, and has been awarded a honorary FRCP honors from Royal College of Physicians. Is currently president of Diabetic Food International, chair of Pan African Diabetic Food Study Group, executive board member of IWGDF for International Consensus, which makes the guidelines, a visiting professor of Staffordshire University, UK, faculty member of Master in Diabetes Mellitus Education, member of editorial board of many journals, national and international. Yes, presented a lot of papers and published a lot of papers. He received the Carol Baker Diabetic Food Medal of Honor, received Life Achievement Award for World Union of Diabetic Healing, and many more accolades to his credit. And he has given us the thing. Dr. Vijay Vishwanathan is traveling. He is in the he's the president of RSSDI, so he's busy. So I now would like to ask our moderator today, Dr. Amit Nagati, to take us over this World Diabetic Week celebration in Southeast Asia. Dr. Amit Nagate is a physician, a diabetologist, and he does surgery like any other surgeon of diabetic foot in Aurangabad. He is based. He has organized the diabetic conference of DEFCON in Aurangabad, and he has a lot of papers and presentations to his credit. Dr. Amit, I think you can start the program by calling the first lecture.
Thank you, sir. Thank you for your kind introduction. I first of all would like to thank DFOT International, the President, Dr. Abbas sir, and Dr. Vishwanathan sir, for giving me the opportunity. Today's schedule, we have three lectures, as Milind sir has already said. So I would not waste much time. Would call our first speaker, Dr. Jaydip Revale. He is a diabetologist and an in charge chairman and consultant diabetologist at Revale Diabetes Nutrition Care Research Center at Satara. He's the founder director of Diabetes Nutrition Awareness Academy. He's the founder of Diabetic Revale Education Academy. He's the founder and chair of DCC Conference which is there held every year for rest of Maharashtra diabetologists and physicians. He has got he's been co-investor in phase 3 and phase 4 clinical trials. He has got publications for national and international journals. He has delivered more than 800 lectures in various organizations across state and national conferences. He runs free type 1 diabetes clinics since 2008. His today's topic is on nutrition. Let's see, Dr. Revale, what he wants to say. Over to you, Revale.
Am I audible? Hello?
Yes.
Yes, Jaydip, you are audible.
Okay. At the outset, I would like to thank Deep International, Dr. Abbas sir, Dr. Vijay sir, RSS Day President, Dr. Milind Ruke sir, my dear friend Dr. Amit, Dr. Tushar Rege sir, for giving me this opportunity to discuss on the nutritional aspects of the wound healing in diabetic food. So this is very unusual topic to talk, but this is equally important. So I will take you through all the nutritional related aspects when patient comes with a diabetic foot ulcer. So we start with the wound healing process. These are the primary processes when the patient lands up into any ulceration. So there is a hemostasis, inflammation, proliferation, and remodeling. So all the wounds have to go through all these phases before we say that the wound is healed completely. And there are so many cells which take care all these processes like fibroblast, then red blood cells, myofibroblast, macrophage, fibrin matrix. Now, the important thing to understand that the ulceration is a stressful condition for the body, and it is a basically catabolic process. So once the patient lands into any type of the ulceration or any type of the non-healing wound, the patient's metabolism goes into the catabolic state. And the process of healing is actually anabolic process. So the journey of healing of any wound is the process of metabolism from the catabolism to anabolism. So we need to understand this basic concept that when the patient is having non-healing ulcer, non-healing wound, the patient is into the catabolic state, and we need to take him into the anabolic state to get that ulcer healed. So with this basic understanding of catabolism and anabolism, let's dive into the today's topic. So it was estimated that 94% patients with the diabetes develop diabetic foot ulcer. 85% of the diabetes-related lower extremity amputations are preceded by the foot ulcer. Now, importantly, diabetic foot ulcers are often characterized by the chronic inflammation when they are compared with the non-diabetic patients. They have the impaired immune response, increased susceptibility to the infection, and suboptimal healing. Per se, diabetes disrupts all the phases of the healing of the ulcer. Diabetic wounds regularly have the prolonged inflammatory phase, due to which there is increased risk of the wound going into the chronic stage. Now, the re-establishing of the blood flow is a very crucial part when there is wound healing is concerned, and this is frequently impaired in the diabetic wound because of the microvascular disease. Now, the scar tissue in a diabetic patient is characterized by the low collagen synthesis. Again, that leads to the vulnerability of the outside stress and the delayed wound healing. Now, the presence of wound has a negative impact on the nutritional status, as we have stated that the patient goes into the catabolic state, and the metabolic cost of repairing the damaged tissue is the additional cost that body is bearing, and there is also some nutritional loss through the wound inflammatory exudate. So now, according to the American Limb Preservation Society, the improvement in the wound care, which includes the nutritional intervention, can increase the life expectancy and the quality of life. Now, wound healing is actually a very complex process, and it requires the adequate balance of the various nutrients support repair and remodeling of the tissue. Malnutrition or the specific micronutrient deficiency may impair the wound healing. Now, there is significant proportion of the patient with the DFU were found to be at the risk of the malnutrition. The number goes between the 49 to 70%, or they are malnourished. Number goes from the 15% to 62%. So this is very shocking statistic that most of the patients who are having non-healing diabetic foot ulcer are either malnourished in at least 50% cases. Now, patients with the DFU have increased risk of being deficient in some or other vitamins like vitamin A, B12, C, D, and E, as well as the iron deficiency, selenium, and zinc deficiency. So usually we don't screen our patients of DFU for this type of the deficiency. Now, malnutrition is associated with the increased risk of the complication, and it increases the length of the hospital stay, morbidity, mortality, and the cost also. Now, this is again very interesting paper published recently in May 2024 in International Wound Journal. Nutrition has everything to do with the wound healing. Health professionals' perception of the assessment and the management of the nutrition in an individual with a diabetes-related foot ulcer. So this was a short survey that how, as the clinicians who deal with the diabetic foot ulcer, how they perceive nutrition as important in the management. So now what came at the end of the paper, what came out of this survey is very interesting. So many health professionals are not confident in their ability in this area. This is very, very important. We know, but we are not confident in what to do. Major barrier for the implementation of the nutritional assessment and the management were inadequate time. So we don't have a adequate time to deal with the nutritional aspect. Lack of knowledge and lack of clinical guidelines regarding the nutritional management of the DFU. Now, the health professionals believed nutrition was important for wound healing. They lacked the confidence and implemented it to their practice. So this is very eye-opener short survey that we know that nutrition is very important, but we hardly do anything when we deal with our patients of the diabetic foot ulcer. Now, when I tried to search the Google Scholar regarding the diabetic foot ulcer and the nutrition, I got almost 42,800 research papers. But when I search only diabetic foot ulcer, the number rose to 1.5 lakh. To 1.5 lakh. So almost 1/3 of the paper or the literature published regarding the diabetic foot is of nutritional aspects. So people have studied nutritional aspect of the diabetic foot ulceration, but unfortunately, probably we are not practicing it very widely or very routinely. Now, let's go into the core of the today's topic. So we have the oral nutritional supplements. So these are the sterile liquids, semi-solid or the powders, which provide macro and micronutrients. So basically these are like protein supplements, which usually we prescribe to the patient, or the liquid formulation, which gives we provide to our patient. So ONS contains proteins, DHA, EPA, vitamins, minerals are the convenient format to support the patient to meet their nutritional requirements. Now, all these nutritional requirements and the nutritional studies in a wound healing has been done on actually pressure ulcers. Most of the studies we see that they are done on the pressure ulcers, and for the pressure ulcer patient, nutritional interventions has given excellent results. So, extrapolating these results, we say that this is equally applied to the diabetic foot ulcer. So now patients with the pressure ulcer, systemic review and the meta-analysis concluded that the high protein ONS enriched with the arginine, zinc and antioxidants were associated with the improved healing when they are compared with the standard ONS. Now, ONS containing adequate levels of the energy, protein, as well as the essential nutrients is a promising component for the care of the DFU. So probably with all our patients who are coming with DFU, we should think of adding one oral nutritional supplement, either in terms either a powder form or the liquid form, which contains the essential amino acids, arginine, zinc, and antioxidants. Patients with the DFU who are taking the dietary supplements were significantly more likely to achieve healing. This is again very interesting study. Now, coming to the energy intake for the adults with the pressure ulcers who are at the risk of malnutrition is ranged to be between 30 to 35 kilocalories per day. And this should be adjusted in adults who are obese. Then we need to reduce. The patient who had a significant weight loss, then we need to increase their energy requirement. Now coming to the fats and carbs, these are the primary source of the energy for the healing process. So all our patients with the DFU should be having the calculated requirements of their fats and carbs. It is not that the fat is always bad. The fat is also essential nutrient to have an adequate healing. Now the adequate intake of carb can prevent the depletion of the amino acids, proteins needed for the specific function like the immunoresponses. Now, DHA and EPA, so docosahexaenoic acid and eicosapentaenoic acid, these are the long chain omega-3 fatty acids. They play the very important role in the immune system. And importantly, they also help in a resolution of the inflammation. So the supplementation of the DHA and EPA or the supplements, oral nutritional supplements who are having DHA and EPA are actually good to reduce the inflammation. Now, conversion from the precursor is generally low in a patient with the DFU. That's why all these patients with the DFU requires the external supplement of DHA and EPA. Coming to the protein is a critical for all stage of the wound healing. It requires for the synthesis of the enzymes involved in the wound healing, immunological processes like inflammatory responses, production of the collagen, connective tissue, and formation of the new blood vessels. So protein is an integral part and it is a part, it is required in every stage of the wound healing. So we cannot have a good wound healing where patient is having the protein malnutrition. So if the patient's protein levels are very, very low, the wound is not going to heal at all. So achieving adequate protein intake is a particularly important in older patients who are at the increased risk of the sarcopenia. We have seen the patients with the diabetic foot ulcers, with long-standing diabetes, they have a lot of sarcopenia, they have the reduced immune response, and these patients require the good quality of the protein, easily digestible proteins for the wound recovery. For the patients with the DFU, protein intake of 1.25 to 1.5 gram per kg per day is recommended in line with the recommendation for those with the pressure ulcer, and is similar to what is thought is desirable for the older adults with the acute and chronic wounds. But again, the most of these patients we know with the long-term diabetes, long-standing diabetes, they have the renal impairment, and probably there where we need to understand the protein requirement and we need to recalculate the protein requirement with the help of the nutritionist. But again, the protein is very integral part of the wound healing process across all the stages of the wound healing, and the adequate protein intake is very crucial for the wound healing. Now, coming to the arginine is a conditionally essential amino acid that contributes to the protein synthesis and the collagen deposition. On the right side, you can see these are the arginine source. So we can have a red meat, then legumes, then pista, the dry fruits, cheese. These are the natural sources of the arginine. So supplementation is recommended for the wound healing if the depletion of the body stores is likely to occur during the stressful of the illness. So any illness that is a stressful factor for the human body. So arginine is most likely to get under the lower level, or there will be depletion of the arginine. So supplementation of the arginine is advised. Then the glutamine is also considered as a conditionally essential amino acid, and as the levels tend to decrease after the major surgeries, trauma, and the sepsis. So glutamine supplementation is again very crucial for the wound healing. On the right side, you can see the natural sources of the glutamine. You can see the egg, beans, and vegetables. So these are the natural source of the glutamine. But the glutamine supplementation in a concentrated form, it is very, very highly recommended after any surgery or any muscular trauma or in a sepsis, and it definitely adds to the fantastic recovery. Recovery becomes very, very fast. Coming to the leucine is again essential amino acid. The preclinical data show that there is a beneficial effect of the leucine on the recovery of the connective tissue after the injury. The combination of the arginine, glutamine supplementation with the beta hydroxy beta methyl butyrate, that is HMB, the metabolite of the leucine, it increases the collagen synthesis. So if you go to the any nutritional store, you will see many combinations of the arginine, glutamine with the HMB. So these are the very classical combinations which we should think of prescribing to our patients with the DFU. Moreover, the mobility is often compromised in a patient with a diabetic wound, and the leucine supplementation may help to reduce the loss of muscle mass. So again, we want our patient not to lose muscle. So leucine is very, very important. And on the bottom, you can see the natural sources of the leucine. We have the super seeds, then we have the red meat, and then we have the nuts, which can provide the leucine naturally. Again, the vitamin A and the vitamin C, we know that this plays a very important role in the collagen synthesis and the protein metabolism. Deficiency definitely results in the impaired wound healing, decreased immune response, and increased susceptibility of the particular wound for the infection. Moreover, there is some evidence with the supplementation of the vitamin C improve the glycemic control also, blood pressure in the patients with the diabetes. In addition, people with the obesity and the patients with the diabetes, hypertension, low vitamin C levels has been compared when we see with the healthy control. So it is just like a vitamin D supplementation. So all the patients with any type of the ulceration, we routinely prescribe the vitamin C for the early wound healing. It decreases the oxidative stress also. Again, the vitamin D plays very important role in the immune system and the muscle maintenance. Low vitamin D levels has been associated with the increased prevalence of the microvascular complications in the patients with the diabetes. Supplementation has shown very beneficial effects in a wound healing, specifically in a patient with the DFU when they are compared with the placebo. It has also shown the improved in the insulin resistance. Vitamin E is again another antioxidant. It maintains and stabilizes the cellular membrane, and that's why very important in the collagen synthesis. It has the anti-inflammatory properties, and it is needed for the vitamin C recycling. So all these vitamins work together. So vitamin C recycling needs vitamin E. So preclinical data suggests that the vitamin E supplementation may support the wound healing and have the beneficial effect on the glucose metabolism also. Again, the vitamin K, we know that the hemostatic capacity that most influence the wound healing. Vitamin K is also cofactor for the synthesis of the prothrombin and other factors. So deficiency may lead to the continuous hematoma formation within the wound, which can impair the wound healing. So vitamin K supplementation, whenever needed, whenever we feel that there is a hematoma which is not resolving with the natural course, then the vitamin K supplementation is very, very crucial. Copper is again a trace element which is needed for the range of the essential enzymes and involved in the development of the collagen synthesis. Again, there are other trace elements like selenium and zinc. They also play the important role as an antioxidant defense mechanism. They improve the immune response to the particular condition, and the collagen synthesis, the zinc is also very much required. In last few years, zinc has become one of the popular supplementation in day-to-day practice. Now, this is again, the niche areas like a probiotics. So probiotics are the live microorganisms which, when administered in an adequate amount, confer the health benefit to the host. So there is a double blind RCT which has seen the effect of daily probiotic supplementation for the 12 weeks, which has been examined the 60 patients with the DFU with the cellulitis on. So participants were randomly assigned to receive probiotic capsule and the placebo for the 12 weeks. So the duration of the trial is very, very small, and the number of the participants are also not really big. But still, this study has found the improvement in the length, width, and the depth of the ulcer patients treated with the probiotic supplement when they are compared with the placebo. And also there is significant decrease in the HbA1c level, total cholesterol, and the CRP level when the patients are treated with the probiotic. So with this is my second last slide. So care of the patient with the diabetic foot ulcer is really complex, and nutrition is increasingly seen as an essential component of the holistic care for the DFU patient. Moreover, it is important to offer tailored medical nutritional solutions. So we cannot have a single formula to prescribe that all DFU patients should be prescribed XYZ supplement. So it should be need-based that will address the special nutritional requirement presented by the patient during the different stages of the patient's wound healing journey. Then current evidence supports the poor nutritional status is very, very common. and it associated with the impaired healing process in a patient with the DFU. However, the number of the good quality of the RCT evaluating the nutritional supplement in the DFU patient is still limited with the varying effect. Patients with the diabetic foot ulcer required good multidisciplinary care to optimize the wound healing, but often an important and overlooked aspect of this in their nutritional status. With this, I thank you again for all of you for your patience listening and for giving me this opportunity today evening. Thank you very much.
Thank you, Jaydip, sir. Thanks a lot. The questions would be taken up at the end of the session. So we would move on to our next speaker, next topic, Professor Dr. Milind Ruke. He's a general surgeon, consultant, diabetic foot surgeon, and limb salvaging specialist. He's a fellow. He has done his fellowship and foot reconstructive surgery from Texas, certified wound specialist from of American Board, HOD General Surgery, Khan Baba Kurla Hospital, Mumbai, ex-professor, ex-associate professor, General Surgery, JJ Hospital and Hyperbaric Division, several publications in national and international journals. He is specifically a Southeast Asia Regional Chair of Defoot International, Royal College of Surgeons faculty over there, Treasurer Mumbai Society of Surgery, and Joint Treasurer Diabetic Society of India. His today's topic is on preventive surgical management in diabetic foot wounds and prevention of limb amputations. Over to you, sir.
Thank you for such a detailed introduction. So basically, when we talk about prevention, and especially in diabetic foot, which is the most neglected disease of complication of diabetes, we always talk about what is happening in the third world country, and we also talk about the health policy to be changed by the government, the educational curriculum to be introduced in MBBS and MS MD level in a larger way, health budget allotment for non-communicable diseases, patient awareness strategies to be implemented, and then catch them young policies in medical colleges that we are doing in DFood International. The most important thing is in all our conferences, the foot is given, a hall which is little away from the main hall A. So that if we can change, I think we can have a better awareness with the patients and the doctors, and the training that will increase, and we decrease the diabetic foot amputations. Now, we all know St. Vincent Declaration in 1989, where they had targeted a amputation prevention of more than 50%. We have still not achieved it. 450 to 500 million patients in the world which are diagnosed diabetes, and double the amount of food to be taken care of. So this is the load, and India is the diabetic capital of the world with more than 77 million diabetic patients we have. So what can be, if the government or the policymakers or the associations only assure but no changes are done, what should we as physicians and surgeons do for these diabetic foot patients who have come to us year after year with faith? What should we do when he gets foot disease? There is a wound which is swelling, the wound which is gangrenous. Should we send him to government hospitals? What should we do? The best strategy for that, even also working as a surgeon for so many years, is the prevention is the best strategy that I feel. And for that we require multidisciplinary approach. Can a surgeon be a part of prevention? Yes, definitely. If the multidisciplinary team wants to detect deformities, correct them, identify high pressure areas, high risk foot, do surgical correction to reduce pressure and avoid recurrence of ulcer as per IWGDF guidelines. So these are some of the guidelines which I'm going to tell you, that if you have abundant callus on the foot for ingrowing toenails or a fungal infection on the foot, there is a recommendation in the IWGDF guidelines to treat that. Then a non-rigid hammer toe, if you have, that has failed to heal with non-surgical treatment like footwear, consider digital flexor tendon tenotomy, which has got a strong recommendation and high evidence. a plantar foot ulcer that has failed to heal with non-surgical treatment and footwear, consider an Achilles tendon lengthening and a joint arthroplasty. Now, this has not got a very high evidence because we have not been able to publish the data, and we only find that they are beneficial for the patient. We were not able to publish data, and that is why when in IWGDF they do the guidelines, they do systemic analysis, review, and meta-analysis. For that, we require randomized control trial, and those are less in this surgical aspects of diabetic foot. Of course, there is also in the guideline that you should not do a nerve decompression procedure. So there are negatives also which are mentioned in the guidelines. So surgical strategy intervention for chronic deformities and ulcerations is an important component in management of diabetic patients as a preventive strategy, and I am sure this will come in future guidelines as more and more surgeons and physicians join hands to do preventive diabetic foot management. Outcomes of these interventions are fairly predictable. You have to believe me, because where we have worked in the Western countries where patients are properly selected and evaluated, especially the blood supply, we get good results. We all think that the only surgery that the diabetic foot surgeons or diabetic foot patients have is a debridement. It is not true. There is now a classification of diabetic foot surgery, class 1, which is an elective reconstructive procedure, which do not have loss of protective sensations we do on those patients, especially the angiography, angioplastic corrections. The prophylactic surgeries, which are reconstructive procedures performed to reduce the risk of ulceration or re-ulceration in patients who have loss of peripheral sensations and or do not have a wound present. A curative procedure performed to assist in healing of open wounds, and emergency procedures performed to arrest or limit progression. So if you have a typical foot like this where the dorsal muscles are weak, the intrinsic muscles are weak, this patient goes into a cavus appearance associated with high plantar pressure. You see the metatarsal heads are directly in contact with the skin, the pad has shifted up, there are hammer toes, and this kind of patients, if we are detected and we do something about this, including giving a footwear, correcting the hammer toes, we can definitely save these patients' foot or prevent further complications. So we have hammer toe repair, we have tendo Achilles lengthening along with offloading footwear in these patients. The common digital deformities are hammer toes, claw toes, mallet toes, where the foot rubs against the insole and you have the gravitational force with the shearing and the frictional force acting in a triangular manner, causing the skin to ulcerate. That unknowingly, because of less sensation, the bone gets infected and you get tip ulcer forming osteomyelitis. So correcting structural deformity with resection arthroplasty is one thing which many Western countries are doing, which augment healing and reduce risk of ulcer recurrence. And in addition, if you have high forefoot pressures which are not getting corrected by your footwear, you can do a percutaneous flexor tenotomy. Also, manual capsulotomy is combined with flexor tenotomy in some centers. So hammer toe correction, you do resectional correction. You have this kind of bunion and claw fit. So deformity correction is a very important step which we did in New York College of Podiatry Medicine, and we found the patient having no recurrence, and patient used to drive his own car, and because that is the situation in Western countries that they have to drive their own cars, they don't have rickshaws or short distance, they have to have their own vehicle and they have to drive. So they are more aware and they are ready for such kind of surgeries. These are some of the studies like Dr. Armstrong had done a single resectional arthroplasty in 31 diabetic and 33 non-diabetic patients, and all the patients benefited with no recurrence at the site. Then you have another small study with percutaneous tendon lengthening done. In 88 weeks, he showed that the pressure decreased with a positive results. Then decreasing foot pressure with tender Achilles lengthening is also one of the prophylactic surgery that we can do, and for that we do a test called a silver cords test to know whether the rigidity is in the gastrocnemius soleus complex or in the tender Achilles, and accordingly we do the release and we give good results. This is not an open procedure. This is something which many surgeons or even physicians can do if trained properly, and this is the gastroc release that we commonly do. Most of the Ganga hospital patients, they do gastroc release for the patients who need them, and this is how after doing it you find a good healing of the forefoot ulcer by decreasing of the pressure. So these are some of the randomized control trial by Mueller and his colleagues done, where percutaneous Achilles tendon alone, when done, they showed a recurrence of about 81%. The total contact cast was alone done, then 81% recurrence was there. But if you combine it with a surgical offloading, the recurrence rate decreased to 38%. Then flexor tenotomy, a very simple procedure. As I told you, there is a tip ulcers which causes osteomyelitis. This can be done with the blade or a 18 gauge needle also, and this causes a wonderful result. This all toes which are curved like this, forming hammer or mallet toes, they straighten out, and you can then this foot can be accommodated in a proper footwear also. If you give a patient's deformed toe a footwear, it will again cause tip ulcer. So it is better to correct the toe deformity. This is a small video where we can see that with a needle only we can do a flexor tenotomy and straighten the toes. So as compared to you can see the lesser toe is immediately straightening after you do a procedure of flexor tenotomy. So this is what you can see how we are doing it. And once he releases the hand, you will find all the toes which are having fibrous, rigid toes are now standing up almost normal. And this toes, when you wear a good customized footwear, will have no toe ulcerations. This another thing called as Keller's arthroplasty, where the proximal part of the proximal phalanx can be removed for a recurrent ulcer on the toe if the hallux rigidus is there, and this can prevent further ulceration. So it's a simple procedure that we do, and we have healing of the foot. So this is the proximal part of the proximal phalanx which is removed so that the toe can move and not be rigid and cause a high pressure area there. This is a patient with humid climate. Patients are not, though TCC is a gold standard, patients are not comfortable, and in spite of wearing half-heartedly the total contact cast and the wound not healing, we do something called as a local rotation flap in this patient, and you can see this flap which was done with the good blood supply. His foot was healed. Even the toes, sausage toes, you don't have to do a transmetatarsal amputation now. You can just do a, you can see the V-shaped incision that we take. We create a fillet flap in the toe area. The finger skin is used after dissection, and after you remove the bones, this fillet flaps are then sutured to the V-shaped incision taken on the dorsum, and only the bones are removed, and this toes are then reconstruction, and that is the magic of soft tissue reconstruction. And you can find this person, though it was not recommended, almost dancing, and he had no ulcerations further for next 12 years. Metatarsal osteotomies are also very encouraging for chronic non-undermining, non-tunneling ulcer below specific metatarsal heads. And here you can see a osteomyelitic fifth metatarsal head was excised and a window TCC was given and the patient healed. So this kind of things also has a very good research evidence, though it requires more evidence to true. So we can do from the dorsal approach or the plantar approach. We can just remove the metatarsal affected head and you can have good healing. So this is pan metatarsal head resection, having good healing. The good news is there are trained surgeons now even in Southeast Asia, especially in India. We have started doing preventive surgeries, healing ulcers by arthroplasty and TL lengthening, correcting deformities for accommodating in footwear and decreasing the pressure. Decrease foot pressures by surgical offloading and elective surgery. Charcot foot, we all know, we are correcting Charcot foot by surgical techniques also, but total contact cast still stands as a gold standard. So we do this kind of circular stabilization. Simple exocystomy can also improve the patient's foot, and you can see the shape returning back. This is a small patient. Now this is an emergency surgery, but even if you don't lose hope and you do a proper debridement, use new things like cement which is biodegradable with antibiotics, and this kind of very bad osteomyelitic wounds also can be corrected, can be external fixed, and after about 3 months when they are the infection goes down, you can do an internal fixation of the patient and you can see that the patient walks on his own feet, and that's a very encouraging sign. So preventive surgery is going to be there in the future, and even a patient curative surgery is going to be. In conclusion, surgery on ulcerated foot assumed an increasingly place in the management. Diabetic patients with peripheral neuropathy or ischemia at high risk for complications than non-diabetics. Careful patient selection and thorough foot evaluation are cornerstones of achieving success. Surgical intervention on deformed foot can obviate many months of unsuccessful conservative care. Early detection and protection of high pressure areas in the foot by surgery and corrective footwear orthotics is the only strategy to prevent loss of limb as a preventive surgery. So this is how we did awareness in this week in Khan Bahadur Kurla Baba Hospital. We had a lot of tests that we did in patients, in the employees, as well as we had this awareness lectures. We had a good crowd, more than 150 patients, and this is how we have done the diabetic foot week, and I hope you have all celebrated it worldwide. So thank you, please take care, and sorry for this a little extended lecture. I think we can have the next lecture again. Rajiv, I can share your lecture. I think let
Yeah, I have informed Raju about that.
Yeah.
Yeah. Now I would invite Dr. Raju Kugal. He's a medical director and consultant diabetologist at Kubil Diabetes Care Center, Mumbai. Consultant diabetologist at Nanavati Super Specialty Hospital, SL Raheja Hospital, KLS Hospital, and lots and more hospitals to be coming. He is invited as a speaker in international.
Amit, let's start, my dear.
Fine,
Thank you.
fine. Sure, thank you.
Thank you. Thank you so much, Dr. Ruke. Thank you, D-Foot. Thank you, Dr. Ege. I'm presenting your slides only. Thank you so much for giving it to me. So today, it's something that we use sometimes without putting a lot of thought and mind into it. And sometimes the rational use of antibiotic and the timing and the time duration to be given is of key importance, especially when we are treating a diabetic foot infection, because we all know that diabetes by itself is an immunodeficient disorder. A person walks for close to 80,000 to 90,000 kilometers in his lifetime, and the pressures he goes through and the neuropathy added to some other issues, the chances of diabetic foot infections increases. So this is the IWGDF guidelines on antibiotic usage in diabetic foot infection. Can I have the next slide, please, Dr. Ruke?
Yeah.
Thank you. Thank you so much for handling this for myself. So we are looking at the IDSA as well as the IWGDF classification. The first is we have an uninfected. That means there are no local signs or symptoms of infection. Next one, and we call it as grade 1. If suppose you have a very mild infection, that means you have any of these two of these items are present. That means that the swelling or induration is more than 0.5 but less than 2 centimeters. You have tenderness or pain or increased warmth or discharge, and we have ruled out other causes of increased skin temperature, like many a time it's acute gout, and we have ruled out a thrombosis or a deep vein or any of this. Then the IWGDF classifies it 2 and mild. Next slide, please, sir. The next one is moderate, and this is sometimes what we normally see in our clinics, where patient has systemic infection, no systemic manifestation, but has a wound or an ulcer extending for more than, or erythema extending for more than 2 centimeters from the wound margin. It's deeper than the skin and subacute, and the tendon, joint, or bone may be exposed. Now, if you probe, probably you will reach up to the bone, and then if there is osteomyelitis, which is often there in moderate infection, you need to add a 0 to it. Next slide. So moderate infection is what we normally see. The other one is severe, where patient is associated with systemic infections, where you either have vital signs deranged, or you have a WBC count or a CRP, and patient may have involvement of the bone, and probe to bone test may be positive, and patient may have osteomyelitis. And these are severe kind of infection as per IWGDF and ITSA. Now, let's go on to what is the guidelines and for that they have mentioned for patients with diabetic foot infections and people with diabetes. Next slide. So again, when do we treat and when do we reduce the chances of infection, and when do we treat? Next slide, please. So antibiotics, actually you use that, we have used it in randomized controlled trial, and do not use it just empirically. Next slide. Also, the antibiotic therapy to a patient with skin and soft tissue diabetic foot infection, at least for a duration of 1 or 2 weeks. Next slide, please, sir. Consider continuing treatment for 3 to 4 weeks if the infection is improving but is extensive and resolving slower than expected, or if the patient has severe peripheral artery disease. Now, next slide. If it goes beyond 4 weeks, then reevaluate the patient. You may have to image the patient. You may have to do some kind of further diagnostic or alternative techniques to find out why after 4 weeks the patient is not showing any kind of resolution of the diabetic foot infection. Next slide. So again, how do we choose the antibiotic therapy? Again, it has to be chosen on probably the causative agent, the severity. We showed mild, moderate, and severe. Published evidence of efficacy of the agent, also whether osteomyelitis is present, drug interactions, agent availability, and cost. Next slide. Again, when we have mild, it's usually a aerobic gram-positive pathogen, which is usually in the skin flora, and mild diabetes-related foot infection who have not received antibiotic therapy. And usually we would give them a gram-positive cover like a cephalexin or maybe a doxycycline or one of them, which covers a good gram-positive cover. Next slide, please. Again, use of pseudomonas, we should not be using empirically unless we have culture isolated from the cultures of the affected site in the same person maybe a few weeks before, unless your strong clinical evidence suggests that the greenish mucus discharge is pseudomonas, and you do not have the kind of resources to kind of do a culture, then probably in Indian settings. But otherwise, we should reserve the pseudomonas coverage. Next slide, please, sir. Again, if we look at mild infections, and if the usually if you have a gram-positive cocci, and you will give either a cloxacillin or a first-generation cephalosporin, and if there is if in other cases, if the causal factors are known, you would look at clindamycin, which also has a very good anaerobic cover, or the gold standard which I often use is the trimethoprim sulfamethoxazole, asking the patient whether they have any kind of adverse reactions to sulfur related drugs, and doxycycline has always been the gold standard as such. Next slide, please.
Yeah.
The view, Dr. Ruke, can we, because the whole slide is getting cut, I can hardly see the slides, there's something in the view. Yeah, this is better. This is much. So again, if you look at mild severity and recent antibiotic exposure, and we are looking at gram-positive and gram-negative rods, that means it has been open for some times. Then we could also look at fluoroquinolones. Now, high risk for MRSA, long-standing diabetics with kidney disease, diabetics with fistula, diabetics on dialysis, diabetes having valves. The MRSA cultures are very positive, very strongly, often in people with diabetic foot infection. And if you're suspecting an MRSA, any of these, Clinda, linezolid, these are drugs which have a very good cover. Patient cannot afford, our good old trimethoprim sulfamethoxazole is a good combination. Doxycycline is a fantastic drug for MRSA as such. Next slide, please. If you have a moderate infection and there's no complicating features, then a moderate infection means you have going up to the tendon and bone is not, and the erythema is more than 2 centimeters. Then you could have an amoxiclav, or you could have a second or third generation cephalosporin. Cefuroxime has always been my choice in moderate, and ceftriaxone has been my choice in severe when we have gram-positive and gram-negative rods. So amoxiclav, second to third generation cephalosporin, either cefuroxime or ceftriaxone, are good drugs if you have a gram-positive and gram-negative and no complicating features. Next slide, please, sir. Again, if you have had a recent antibiotic exposure, and that's what normally happens, is that patients have already exposed themselves to antibiotics, and then when they come to us, then you require to give them either a ticarcillin clavulinate or a piperacillin tazobactam combination, or one of the carbapenems. So again, depends on the prior therapy, but usually we would hold on to a carbapenem and probably use a piptaz or a ticarclav combination initially, if there has been an antibiotic exposure and it's been around 2 to 3 weeks and the patient is not showing any resolution of infection. Next slide. Again, macerated ulcer or warm climates, again, the guidelines do not recommend, but our usage of antifungals is very high when we have interdigital macerations, and a short course of antifungals does help also in delineating the wound. But if you have a gram-negative rods, moderate infection, again, the piperacillin tazobactam combination, along with the group 2 of carbapenems and the ceftazidime, which we have been always using for the last 3 decades, is a good combination, especially if you have macerated ulcer, which normally our patients have. Warm, humid climates, gram-negative rods would require this kind of a coverage. Next slide. Again, ischemic limb necrosis, gas forming, antibiotic cover, but importantly, we need to make sure that the vascular salvage, and if it's a critical limb ischemia, we make sure that the vascularity has been restored, whether it is done with an intervention or without an intervention. But it's important, otherwise none of these drugs work. But usually if you have a severe to moderate infection with a gas-forming organism or necrosis or ischemic limb, and usually you have a combination of ischemia and neuropathy, then your combination is usually going to be a piperacillin tazobactam, ticarcillin clavulinate, and probably a carbapenem added to either a second or third generation cephalosporin. So Here you will have to cover a lot of gram-positive, gram-negative, as well as anaerobic infection. So clindamycin comes very well here, and you may not require to use a metronidazole. So clindamycin with a drug which covers gram-negative rods, which either it's a piperacillin tazobactam or a third generation cephalosporin, becomes a very good coverage in patients who have these kind of infections. And usually these patients would have some kind of sepsis also. MRSA risk factors, and we have isolated MRSA, linezolid, initially teicoplanin if the patient's kidney is fine, vancomycin, or if the kidney is very badly fired. We use vancomycin, especially in dialysis patient, because it can be taken care of. But we need to make sure how the kidney functions are before using vancomycin. It works wonders, but linezolid, teicoplanin, very, very good drugs in MRSA. But again, you have to have a culture positive to be using these drugs as such. Again, if you have risk factors for resistant gram-negative rods and ESBL like a carbapenem, which often is used much earlier, and I would say that we need to reserve this because a lot of people use these carbapenems very early. Ciprofloxacin, aminoglycosides are good drugs to be used in gram-negative rods. Next slide. Again, this is very important because many a time if you have an underlying osteomyelitis, the duration of antibiotic therapy is important. And if the osteomyelitis is at a place that you are not able to resect or have a reamputation, it becomes difficult, and the duration of antibiotic therapy is important. So consider a duration of up to 3 weeks of antibiotic therapy after minor amputation for diabetes-related osteomyelitis and positive bone margin culture, and 6 weeks at least for diabetes-related foot osteomyelitis without bone resection. I usually at least give 6 weeks if there is osteomyelitis with or without a resection. That much of time is required for the bone to heal. Next slide, please, sir. Again, if you what is the route of administration? Usually superficial wound to a class 1, which is a moderate wound up to the tendon, you can give oral, but majority of the time patients come much later, and you would require to give them an initially parenteral route followed by a long-term oral route, and depends again on the vascularity of the patient and the peripheral vascularity of the patient to decide the route of administration of the antibiotic as such. Next slide. So use the outcome at a minimum follow-up of 6 months after the end of the antibiotic therapy to diagnose remission of diabetes-related osteomyelitis of the foot. It has occurred that ill-treated or under-treated osteomyelitis flares up after a year and two. Patient comes back with osteomyelitis and web space infection, and sometimes with a digital gangrene. Next slide. So urgent surgery, I think the diabetic foot team involves all these people where the surgeon is the leader, followed by us. And sometimes we need to make use of interventional radiologists also. And the imaging team has to be in sync with the entire team. So urgent surgical consultation should be obtained in case of severe or moderate foot-related infection, complicated by extensive gangrene, especially necrotizing fasciitis. A high index of suspicion is especially important when we are looking at necrotizing infection, because debridement within the first 24 to 48 hours is important, with a very broad spectrum antibiotic coverage to prevent sepsis and critical limb ischemia, and to remove the infected as well as the necrotic tissue. Next slide, please. These are a few recommendations that in people with diabetes, peripheral arterial disease, and a foot ulcer or gangrene infection involving any portion of the feet, obtain an urgent consultation by a surgeon as well as a vascular specialist in order to determine the indications and timing of the drainage procedure. Next recommendations. The next slide, please. Consider performing surgical resection of infected bone combined with systemic antibiotics in a person with diabetes-related osteomyelitis of the foot. Next recommendation, please. Consider antibiotic treatment without surgery in case of forefoot osteomyelitis without an immediate need for incision and drainage, without peripheral artery disease, without exposed bone. Very difficult in our scenario. Suggestion: not using the following treatment to address diabetes-related foot infection. Adjunctive GCSF, which we normally do not use much. Topical silver preparations, are being used, negative pressure with or without installations are being used. Next slide, please. Not using sponge, extremely important. Cement, antibiotics in combination with systemic antibiotics. Topical antibiotic does not have a role in diabetic foot infection, and this is very, very clear. And there are a lot of other topical agents which can help in the healing of the wound. But topical antibiotics with or without systemic antibiotic does not have any role in foot infections. Suggestion not using an HBOT or topical oxygen therapy as an adjunctive treatment for the sole indication of treating a diabetes-related foot infection. Next slide, please, sir. So at the end, there are a lot of we need to classify the wound. That is extreme. We earlier had the Wagner's classification, and now we have the IWGDF classification and the ITSA. And antibiotic, the choice and the duration and the route of administration is something that clinically only we can decide. I hand it back to Amit, Dr. Rege, and Dr. Milind Ruke to take it forward. Thank you so much.
Thank you, Rajiv, for your lucid lecture. Now I will invite our two panelists, Dr. Tushar Rege, sir, who is a consultant fellow in diabetic foot surgery and a diabetic foot surgeon to Governor of Maharashtra, and he is currently a president of IPA Maharashtra State Chapter. And the second panelist of today is Dr. Prasad Bale. He is a consultant surgeon in Kurla Baba West Hospital, and specialized training he has received in diabetic foot and wound management. Welcome you both on the board. So let's start our panel discussion session, for which I would initiate the panel discussion by asking a question to Dr. Tushar Rege, sir. Sir, could you tell us that what kind of structure is needed for a hospital or a general practitioner or a diabetologist to be there in his clinic to start up for basic diabetic care?
Thank you, Deefoot, and thank you, Dr. Milind Ruke, Dr. Amit Nagate, and panelists, Dr. Jaydip, Dr. Rajiv Kovil, Dr. Prasad. Just a correction. I'm the past president of IPA, and my esteemed colleague, good friend, Dr. Rajiv is now the president.
Okay. Okay.
Yeah.
Congratulations, Rajiv.
It's a pleasure being with all of you. I had heard talks on how to set up a diabetic foot clinic, and one of the persons who had mentioned it that you require a passion to start diabetic foot clinic. That is the basic requirement of a diabetic foot clinic, because it's not an easy job with a lot of so-called smelly patients, dirty patients, infected patients. But what you require is, of course, in addition to passion, is a good second line staff or a second line of treatment givers, caregivers, because the volumes are huge in diabetic foot. And it all comes to dressings, wound evaluations. So training nurses, paramedics, ward boys, and dressers who will actually take care of all these wounds and understand the basics of these wounds, whether these wounds are infected, non-infected, static wounds, spreading wounds, active wounds, chronic wounds. I think that is something which helps in starting a diabetic foot center. Other than that, of course, the basics of a good accessibility. It cannot be a place which is non-accessible because a lot of people are immobile. Number two, having the basic equipment like a biothesiometer, a handheld Doppler, and if possible, a Kodia scan, a TCPO2 machine, and the basic dressing material. This caters to forming a good diabetic foot center.
Okay. My next question will be to Dr. Milind Ruke, sir. Sir, as Revale sir has mentioned, that we should have a passion and training regarding that. So, what kind of trainings are available in India in regarding aspect of diabetic foot management?
Dr. Milind, unmute, please.
Please unmute yourself.
Sorry. So
Yes, sir.
we initially had our seniors who used to teach diabetic foot, not as a curriculum which was, recognized everywhere. So we had the likes of Dr. Sharat Pense sir. We lost recently. We had Dr. Vijay Vishwanathan, who was ex-president of D Food International. We had Dr. Bar also as a surgeon teaching people. So we had these MUHS fellowships. We had an Amrita Institute where initially about 15 years back or 20 years back, this just started something. We recently launched in Chennai in Dr. Vijay Vishwanathan's hospital, the School of Podiatry. I think you were also there. And we
Yeah.
had a podiatrist from US, from New York College of Podiatric Medicine, and we started a certification course even for the podiatry assistants, and we are going to now increase it in the next 2025, and we are going to be associated with APWH, Association of Physicians of Wound Health. So this kind of things are going on. Now we are trying to see that this curriculum comes in the uh, medical education in India. What happens in Western countries, they once you graduate, you do an MBBS, and then you either become a podiatrist or you go to an orthopedics or general surgery. In India, we do not have that. That is missing. That podiatry branch is missing, and podiatry is also, I do not know for what reason, has been looked down upon. You know, I remember somebody introducing me that Dr. Ruke was a general surgeon. Now he has stepped down as a podiatrist. That is how I was introduced. So then I changed the thing and I said I am a general surgeon and a limb salvage surgeon. So this is the thing, that is the level of things we do not understand. Ki it's a very important, a passionate job. So we require a lot of training. We require a lot of authenticated and accredited courses in India. That is what my feeling is.
Okay.
Can I
My
just
next.
add to this, with your
Sure.
permission, Dr. Amitya?
Sure,
As
sir.
Dr.
Go ahead,
Ruki
please.
said, what to the best of my knowledge, you will know better. In the US, podiatrists are people who are trained in up to the ankle joint. They are not considered surgeons, and they are not supposed to operate or treat anything above the ankle joint. That is what I got, and therefore probably people must have thought that podiatry is one step below. But
No,
considering the huge burden of diabetic foot, I think it's an important thing.
no, I think that's not true. They are operating above the ankle also. That was what first was thought. But the problem is after MBBS, they just jump into podiatry. So it is like doing a diploma in ENT or a diploma in gynecology, something like that. So that is why it was considered as a little lesser branch. But they were operating when I did my fellowship. Even the DPMs, they are called as diploma in podiatry medicine, they were operating everywhere in their foot. They were also using treating necrotizing fasciitis of the entire leg. They were treating the varicose veins also.
My next question is to Dr. Jaydip Revale. What kind of balanced nutritional diet would you give, or would you prescribe to a diabetic foot uh, person who is having a neuropathy? One, I would be just dividing it into one three subpoint. One with a neuropathy, one with a wound, and one who is with a wound with admitted in ICU or in general hospital, or would be who has undergone a surgery and is now in a hospital setting. So, what kind of treatment or what kind of diet schedule would you recommend to them?
Okay, so that is very interesting question, and thank you, Amit, for taking up this question. So first thing is nutritional requirement of every patient is really different. So we cannot simply give a printed chart to every patient that you just follow. So we need to understand that all the patients who are having active infection are in a catabolic state. The patient who are not having any active infection or no ulceration, like patient with the diabetic neuropathy only, he is not in catabolic state. So we need to give a supplementation like ALA or maybe trace element like zinc, magnesium, and glutamine. This works fantastic in this patient. If the patient is having motor involvement, then they are having sarcopenia also. Then we have to look after their protein requirement also. Being diabetic patient, we are always concerned about the carbohydrate intake. So we want all our patients to have a less carb and no fat something, because most of the patients are obese. But again, zero carb or zero fat is not the ideal thing, because carb and fats are equally important, though in a right proportion. So we need to customize their diet as per their BMI and the protein requirement and the fat requirements. Because if you remove all the fat from their diet, they will constipate. So, so for diabetic neuropathy patient, our focus mainly will be on neuro supplements, trace elements like zinc, magnesium. Arginine is again very good supplement. Then glutamine routinely we are trying to give if the patient is affordable. And we do give a good protein supplement with having very less maltodextrin, less fillers, with a good quality, good digestible protein to avoid the sarcopenia. The patients who are hospitalized, they are into catabolic state. So their metabolic rates are very high. So we need to convert them from the catabolic to the anabolic state. So for that, their nutritional requirements are actually higher. Though the patient is eating less, their nutritional requirements goes on a higher side, and they need a customized diet. They need a good protein, and the glutamine is very good supplement to give in any acute or the chronic illness. So glutamine is a fantastic supplement. We as a doctors, we don't use it much, but all these sport nutrition shops, you can go and just see who are the fitness freak people. The glutamine is one of the best, and it fastens recovery, any acute or chronic illness. So for hospitalized patient, good protein intake. Then the glutamine is one of the best supplement. Then the magnesium and zinc and arginine combinations are there in the market. So this definitely aids to the recovery. But again, the cost is a little bit barrier with this patient. For the hospitalized patient, protein supplementation, because of the digestibility issue, we generally provide the pre-digested proteins to them. If you give the routine protein supplement, sometimes they do develop the bloating and the loose motion. So half digested protein supplements are there in the market. So we should prescribe half digested protein supplements.
Okay, so what kind of protein requirement or what kind of protein dose would you give per day to a patient who is hospitalized?
So it is generally 1 to 1.5 gram per kg per day.
Okay. Okay.
Can
Thanks.
I can I
Uh,
can I ask
yeah,
Jaydip
please
one?
go.
So if there are so much requirement of this trace elements and proteins, so is there something that orally can be given which can have zinc, arginine, and glutamine, which are more important, or separately we have only IV preparation, zinc drip, we have IV glutamine. What is the combination you think we should give patients,
So
which will
naturally, natural sources are always there for even glutamine, arginine, leucine, and zinc, copper. But again, the limitation of the consumption is also there. So how much any diseased person or the person who is already in a catabolic state with the infectivity, his appetite is already down. So that time we can't expect these people to eat in an adequate quantity where the daily requirement is met. So generally nuts, green leafy vegetables, and in fact red meat, these are the good source for almost all the vitamins and the minerals. Supplementation in terms of the IV, that is not recommended. Most of the supplements are not available also. Though there are some supplements which people use in a different patches, where they say that we are giving all these amino acids in a saline vials and we are flushing the vessels. So these are the different people who practice very different type of the pathy, where they claim that they flush all the vessels and remove the block. So coming to the basic guidelines, so we should encourage the people to have basically cereals, pulses, and nuts. So most of the dry fruits are very good source of the these minerals and vitamins. But again, the recommended daily allowance will not be made, because the quantity they need to eat is very high quantity and the duration will be long. So during the acute illness or the chronic illness, it is always better to have one supplementation which will have combination of the zinc, selenium, magnesium, arginine. Glutamine generally comes in a powder form. It is a tasteless. So one tin of approximately 600 rupees will last for 2 months basically. So one scoop per day in water, and it is very tasteless, so patient can comfortably have it.
Thank you. Thank you. My next question is to Dr. Prasad Bane. Sir, uh, you are practicing in a medical college-based institute. So, what kind of patients do you see in your practice or in your college days walking in, and what kind of preventive aspect would you like to guide for rest of the doctors to for the prevention of wound ulcers and how to take care of them?
Okay, as far as diabetic foot ulcers are concerned, diabetic foot patients, the patient load is very high in teaching institutes, in secondary care, municipal institute. The facilities which were not available initially are made available with the help of administration. Everybody knows now about negative pressure wound therapy, offloading, the diabetic foot testing. All these things, the specialty clinics are becoming more widely available for all our patients. Now the problem comes with the patient education, that how much these facilities are needed for them. Because when we are asking them to stay for a longer stay in the hospital admission, they may not be ready for that because of loss of working hours. Now you have to make them aware that that will help them, help them in long run. Because once they start walking, they expect that I will go back to work. I wear the shoe and I'm standing on it and I'm walking. But to make them understand that this is a long process, it takes its own time. But gradually, with all this awareness and everything, most of our patients are more receptible. They are understanding the need for all these newer therapies, and that's how the whole process is also changing now. What we need to understand as healthcare workers or from doctors, even if we are working in a private setup or even if we are working in a municipal setup, that how much the specialty clinic approach we can give to this particular problem, and how much the patients who are approaching you are receptible for your care. So both things are difficult to balance, but gradually it will work.
Okay, okay. So my next question is to Dr. Rajiv Kovil, sir. What kind of antibiotic profile or what kind of antibiotic would you prefer to use in a CKD patient, end stage CKD or stage 3 or stage 4 CKD in a diabetic foot infection? Are you there, Rajiv, sir?
I think Rajiv has.
Yes, Amit, can you just repeat the question, please? I'm so sorry. I missed it. Yeah.
Yes. What kind of antibiotic would you use in a CKD, stage 3, stage 4, in a diabetic foot infection?
Good, and that's why multi-speciality care is important. I would refer to the nephrologist because these cephalosporins and many of them, the dosage is based on the GFR, and there are few nephrotoxic agents as well that we are aware of. So if there is a CKD, I think two things I always call nephrologists is that one, when I have to change the antibiotics, and two, when there's a salt imbalance, and it's better handled by a nephrologist. So I think a lot of aminoglycosates, quinolones, as well as the cephalosporins need a lot of change in their dosages. So it's important that it's all based on the EGFR, and I leave it to the expert for doing
Okay.
As Dr. Rajiv rightly said, just making you rightly said it, yeah, that I feel almost all antibiotics can be used except aminoglycosides with caution, and the dose is rightly decided by them. What I gathered during the course is something like this, that in the initial part, as surgeons, our aim was just to give maybe half dose if there is a renal problem. And my nephrologists say that, no, when you start, what is important is that you control sepsis first. So at least give a loading dose. And then, so here you want to attack the infection first. So at least in the first 24 hours, you give a regular dose as if there was no renal problem. And then let the nephrologist titrate depending on, as Dr. Rajiv said rightly, the EGFR.
So what we can do, what according to you, sir, is that give a loading dose of 2 gram of this thing, what we say it as imipenem or meropenem, and then step down and let the nephrologist decide to what kind of dose of 500 mg of mero is used or 1 gram mero is used, whatever, depending on that. Load it first, give it a shot, give it a missile first, and then routine bullets can be hit to the targets. This is what
something like that.
right? Something like that. Something like that. Okay. Okay. So my next question goes down to Dr. Milind, sir. Sir, what kind of surgical procedures would you use for as an advanced, what we say it as offloading procedures? What kind of procedures are now being used, and what kind of procedures are there in your pipelines?
So basically, it is not that you can use a procedure, you have a standard procedure for a wound. There are a lot of things that we surgeons look, and the most important we look is the blood supply. Because whatever surgery you are going to convince the patient to undertake, you have to at least predict that your results are going to be at least 80 to 90% good, and that all depends mostly two things. One is the blood supply and the second is the offloading. So we have seen a lot of patients. I know that Tushar will agree that your blood supply till the dorsalis pedis proximal and the proximal part of posterior tibal is good, and suddenly there is a monophasic flow in the distal part, and even the capillary refilling is more than 5 seconds. In that scenario, when you're operating on the toes or web spaces, it's a little dicey thing to think. So now we are doing TCPO2s, and even TCPO2, the technical way to do the TCPO2 is not present in Mumbai in that special way. Sometimes the technically you may go wrong and you may do a surgery and you may find a different ball game. So the safest thing to do is to do, as I told you, do a silver quartz test and do a 4-foot pressure decrease. You can do by doing a tear release or a gastroc release. This is the basic treatment. Second thing is, as I showed you, the flexor tenotomies, the hammer toe corrections, the extensor tendon lengthening. These are some of the things. Now there are certain advanced things which are coming, like putting silicons in the pad which is lost in a patient with intrinsic muscle atrophy and all. So all these things are there, but how much the patients are going to afford and how much is it long lasting? No, it is not long lasting. So one of our friends, Dr. Curry, used to say that, and most of the people say, the diabetic foot doesn't heal, it is always restricted. So restricted walking, small slides, good offloading footwear, convincing them to wear it almost 24 hours should be the awareness level, the counseling, the offloading, and the blood flow. So there are a lot of physiotherapy exercises also which are taught to the patients to increase the blood flow. The collaterals develop slowly, naturally also in the patients. So all this offloading surgeries and the things which I described in the preventive and elective surgeries can be practiced easily by little training by all the surgeons and orthopedic surgeons. Tushar, you want to add something?
No, these surgical offloadings are now coming up. Earlier, what we used to feel is it's only the footwear which was there to offload, that is from outside. But now, as we train, very frankly, I'm also in this training phase of surgical offloading, not really conversant very well, but I think that will be there to stay, surgical offloading. Our only problem is that whatever you do, you must realize that this is a neuropathic food. This is a food with the end products of glycation acting on all the ligaments, all the connective tissues, all the tendons. And therefore, whether we do, it is now important to see the long-term effects of this surgical offloading, whether it's really working or not working. That only time will tell.
Okay, sure, sure. I would like to ask Dr. Prasad Bane, sir, what minimal test would you like to do for to evaluate a diabetic foot? For evaluation of routine diabetic foot, if a routine diabetic patient comes down to your OPD, what minimum investigations would you like to do to evaluate the foot? Bane, sir.
You are
Sorry. Uh, First of all, the pressure points we need to check where exactly patient is having more pressure and developing the pressure source. That can be done by computerized pressure scanning. The other things are like sensation, as Sir was saying, it's mainly a neuropathic food. So you have to test the sensations, which part the patient has lost the sensation, and there exactly we need to give offloading or certain uh, uh, pads which will help in reducing the pressure, and that will further prevent the pressure ulcers. Now, every test will have its own significance, and as it progresses, the disease progresses. ABI is another one. As in the clinical setting, we can check for the ABI, that is ankle brachial pressure index. We routinely do it in our clinic using Doppler, handheld Doppler, measure the pressure in the ankle and measure the pressure in the brachial pulses, and then calculate it. If it is less than zero point 0.8, obviously it is gangrenous foot. It is more than 1, then again calcified vessels between zero point 0.8 to 1.2, it's normal. So sensations, pressure, vascularity, these are the first few things which you will check. Other than that, we have to check for the ischemic changes in your diabetic foot. Brittleness, developing signs, cons, any small trauma which can lead to further chronic non-healing ulcers. Whether the patient has already developed a chronic diabetic foot ulcer, then what is the condition? Whether it is in the inflammatory phase or it is already in the arrested proliferative phase. So that will again change your decision to for the wound cover, closure, or regular dressings and offloading would help in the healing. So these are the few things. Other than that, what other certain invasive procedures are there, like CT angio is there, which can be done to check for the vascularity of the foot involved, calcification of the vessels. Doppler, before CT angio, there is a Doppler which can be done to see whether it is a monophasic, biphasic, or triphasic blood flow, and whether the digital arteries are involved or not. The simple procedure which we can do is a handheld Doppler. If you have it in your clinic, that is the best blessing you can get to check the vascularity of your diabetes.
Sure, sure. Thank you. Thank you for the detailed elaboration. Thank you. I will request Milind sir, in case he has some questions, he can proceed with it, or else we can close the session.
So basically, I really thank all the delegates who have joined and the faculties who have joined on this day. A little different, odd day, a working day, but we have all got together to celebrate this World Diabetic Day, and which is actually tomorrow, but we are doing it in the entire week for DFood International. I really thank all of you who have joined this discussion and made it a great success. Now the problem is we have all discussed the theme of this World Diabetic Day was well-being. So we have discussed about the well-being, social well-being, mental well-being has been not been discussed. So that is where the most important thing, that the patient of diabetes is always under stress, strain. I had a patient, a 32-year-old boy, having bilateral diabetic foot disease. So we have now a era where we are getting diabetic foot on both the legs. Young patients coming with diabetic, as Jaydip also has said about the nutritional aspect, where lifestyle is completely changing, and we have genetic issues, mother and father both diabetic, and so you have a 75% chance that the children will have diabetes. And we had Tushar telling about his clinic and how he treats his patients in the medical college. What is happening, we do not have sufficient staff to look after the patients in medical colleges. We do not have wheelchairs. We cannot tell the patient, okay, you are offloaded for 24 hours. The sanitary facilities even in medical colleges are far away from the patients where the beds are, so the patient has to walk there. So there's something like there's samadhan offloading we may use, or something like that. So there's a vast improvement is required in developing nations like India and Southeast Asia, and this is where we are representing. This is a small thing representing Southeast Asia, and this is what we are supposed to tell the policymakers. The D-Food International can write to our governments of the Southeast Asian nations, where the prevalence rate is going to be very high. After this, it will be sub-Saharan Africa, where the prevalence rate will be high. These countries, if no policy change is done, then we are into a big trouble. So such meetings and such kind of awareness has to be there for the development of diabetic foot knowledge, awareness, training, and many other things, so the amputation rates can be covered. So I thank all of you. I thank all the delegates without which this will not be successful. We have in our college people looking at the thing, though the logging is only one, but we have a screen on which people are looking to what we have said. I thank Dr. Jaydip, who has been always very supportive about giving this lecture. Dr. Rajiv in his busy schedule, and he has talked on the antibiotics. I thank Dr. Tushar Rege, who has always been my friend, and always we together are in a lot of functions as surgeons. We have Dr. Prasad Bane from the medical college, and Dr. Amit Nagate being doing this moderation so well. I thank Dr. Abbas and his team of D-Food International, Dr. Vijay Vishwanathan, who is doing a great job in RSSDI, and I thank all of you for attending this from the bottom of my heart, and we continue this process of awareness and spreading education. Any last few sentences, anyone, all of you can say, and then we can close this discussion. I think you can start from Jaydip, Tushar, then Amit and Prasad, and Rajiv if he's there logged in.
Thank you, sir. Thank you, D-Food International, for this wonderful opportunity, and it is the need of hour. And I think this is very great initiative that this type of the meetings are happening across the 7 different regions on the occasion of World Diabetes Day. So World Diabetes Day is just one occasion to for clinicians and the healthcare takers like us to do the awareness program. I think we should do more of such programs and spread the education, as Regis rightly said, that the education is the only key. And Professor Abbas sir also has said that the education is the only key to prevent the diabetic foot ulcerations and the amputation. So I thank you, D-Food International, and Milind Ruke sir and Vijay sir for this wonderful opportunity. And I look forward to participate in future meetings also. Thank you.
Tushar,
Milind, as you rightly said, St. Vincent's Declaration years back, and still we have not achieved anything literally. So, as we have all been mentioning, Dr. Jaydip said just now, and echoing the same things, that it's only education, education, education. I think education at doctor's level to begin with, and education at the patient's level, and education at the paramedics, who are really the backbone of diabetic foot care, I feel. So at this 3-pronged approach of education to these various levels, will actually see a fall in diabetic foot problems. Because we all as surgeons and we all as treating diabetologists are aware that once a person has a foot problem, he and his family is doomed. Literally, this is the word. They are doomed financially, socially, psychologically. It's absolutely a bad thing. I feel the two things which really harm a patient is a kidney disease where the patient goes in for dialysis and a diabetic foot where we actually confine him to bed. And all the things of so-called we tell the patients to offload are again disastrous. I feel offloading is not the answer. They go into cardiac problems, osteoporosis, bed sores, lack of revenue, lack of esteem. And though we are actually maybe healing an ulcer, we are not treating the patient. So, sir, I think this is a wonderful initiative. Let's all educate patients. And thank you all for being a part of this.
Thank you so much. Thank you, everyone. I think, thank you, Dr. Ruke, Dr. Rege, Jaydip, Amit, Dr. Bane, D-Foot. I think you put it right, sir, that diabetic foot is such a huge handicap, and disability living puts a lot of stress. Apart from the length of life, it's the quality of life which is very, very poor. And the rule of 50 is so obvious in people with diabetic foot. You know, you have a foot and then you'll end up with a creatinine, and you'll end up with heart failure and bed sore. So it's a downhill, and I think we need a lot more people like you for our people with diabetes. Thank you so much.
Thank you, Rajiv. Prasad, you want to say?
Yes, thank you very much, sir, for this opportunity and this initiative. This is a great initiative. I joined late today. Actually, I was trying to see Amit's name somewhere. It's not there. Then I saw it's still there somewhere with your name there. So uh, it's very nice to, this initiative is excellent for patient education, for all over the world, and for healthcare workers, for doctors, for nurses, for everybody. And I hope we all, as doctors and surgeons, we all continue doing this for many years to come, for the benefit of the patient and for the diabetic ulcer disease itself. Thank you, sir.
Amit, you can have the last word before we end.
Yeah. Everybody is talking about prevention. Everybody is saying that diabetic foot infection is a worse problem with kidney disease is again worsener. But for me, as a diabetologist, as a diabetic foot care expert, I always say this word. Jaydip knows it very well. All the people who are with me knows them very well. The dictum which I follow or dictum which I say all the time is that the instant the individual, you label the individual as a diabetic individual, from that instant that his feet become a diabetic. You have to take care of the feet from that same instant, from the day one. Then and then only this problem is going to get resolved, or it's going to get into our own hands, and the problem is the load is going to go down. If in case you are not taking it from that end, then the burden is going to be very high, because individual is one, feet are two. So we have to multiply it again. Number of diabetes patient, you have to multiply it by two. So the burden is going to go high. It would be a very high burden. So we have to catch, and we have to start the prevention from the day one when we label the individual as a diabetic individual. This is what I feel, and this is what I practice. Rest to you, sir.
On that note, I think we can end this program. Very nice, all of you, to see all of you. And thanks, Zaima, who is the secretary to D-Foot International of Dr. Abbas. Are you still there, Zaima?
Yes, I'm here.
Yeah. So I think we all thank you for so nice, we are streaming live all over the world. So thank you for your cooperation and help. And
Thank
regards
you.
to Dr. Abbas and Dr. Vijay.
I will
So
do. Thank you.
thank you. Thank you, everybody. Have a nice evening.
Thank you.